and other people can join us as they make it. I'm going to start with a prayer that just enables us to stop for a moment and remember why we're gathering, in whose presence we're gathering. We pause in quiet reflection to offer this prayer for a peaceful world. In our individual and personal ways, we call upon the Holy One who sustains our lives and who inspires us to live with compassion and kindness and peace. We ask for daily guidance in all of our personal relationships, in our work and our play, and in our community involvement, that we might model the possibilities of peace and justice in everything we say and in everything we do. We pray for wisdom and compassion within the hearts and minds of all world leaders who have the power and the responsibility of making decisions that impact the presence of peace. We pray for courage, dedication, and integrity within the spirits of all those who work for peace around the world. And we pray now for those who harbour thoughts and feelings of hatred, violence, and greed, that their hearts and minds and souls will be transformed into your likeness of compassion and kindness. We're thankful for your presence here today within our lives, and we ask for your blessing as we try to live peaceful and just lives, seeking ways for all people to live in harmony and peace. Amen. Amen. Now over to Warren to introduce this evening.
Well, Malika, do you want to go over the rules first?
Yeah, okay. So after the speaker, there will be the opportunity for questions, but not statements or stories of other personal experiences. However, we may be able to create other opportunities for these. Questions initially can be put to the host using the chat while the speaker is talking. As we know, the topic of our sessions that we're running is around Black Lives Matter, and the prejudice and racism against BAME and minority groups is not the same. They're two completely different stories. Black Lives Matter is not saying that only Black Lives Matter. We know all lives matter, but we are addressing the acute and current issue that Black Lives Matter and that lives of Black people are in danger, incredibly in the 21st century, and that racism against Black people has been and is worse than against all other groups. And there is a lovely short story in Luke 15, the parable of the lost sheep. I'm not going to read it out today, but if you ever want to access it, you can. But it gives a biblical understanding of how to understand Black Lives Matter. This is a space for us to come together and learn more about Black Lives Matter, to listen intensively, learn and ask questions. You may find it best to set your screen to speak of you using the control at the top right of your screen, which will help you to see and focus on the speaker clearly. We have 1 hour, so we need to be strict with the timing. Can we ask that those people that are regular sharers and regular ask questions, would it be possible that we can give those that we haven't heard from the opportunity to share and ask their questions today? And if there's anyone who regularly shares but has got something really important that they'd like to ask, we're asking that they put their comments in the chat box, and then we can answer the questions that way. Thank you.
Thank you, Malika.
Welcome.
And thank you, Jane, for the prayer and starting us off this evening. It is my pleasure this evening to welcome Faye Bruce, who is our guest speaker for this evening. And the theme for the evening is, I suppose, Black experience and inequalities in health and healthcare. And in many ways, Faye is the ideal person to be dealing with us, with this, and helping us through an exploration of it. Faye is the chair of CARN, chair of the board of the directors of CARN, the Caribbean and African Health Network of Greater Manchester, also one of its founders, one of those with a vision who saw the need for it. And she's also a senior lecturer with a master's in healthcare policy and management, PhD. Have you got your PhD? You're still working towards it? Can't hear her. Okay. It's focused on the management of chronic conditions within diverse communities. Faye came into this by having been a qualified nurse in the NHS and the private sector, working across a variety of specialist areas, including orthopedic and surgical nursing. Faye's research expertise focuses around access to education and training and development among healthcare support workers, and also looking at the widening participation and higher educational achievement. She's also focused on chronic disease and self-care management among the African and Caribbean community, and also looking at healthcare literature and its use within diverse communities. I've also had the pleasure of getting to know Faye through the health and social care work that the interfaith communities have been doing in Greater Manchester, along with other projects as well. So you don't want to hear any more from me. So it gives me great pleasure to ask Faye to lead us through this evening, please.
Thank you, Warren, and thank you for the welcome and for the invitation to this series. I'm really delighted to be sharing some of what I've been doing around health inequalities in the Caribbean and African community. But I wanted to, Charles is here on the call, and he's going to operate my slides for me so I can concentrate on what I'm saying. Charles, do you want to just put the first slide up?
Warren is going to make me co-host first, then I can share.
Sorry, I said I just have done. Just there you go. It's as you were saying it. All yours.
Right, thank you. So yeah, so the title for the presentation this evening, I'm doing something slightly different to what you've probably had in the last few weeks. I don't know if it's my lecturer hat or what, but I just wanted to do a presentation just so it can be quite clear about the kind of journey that I've been on to address health inequalities in the Black community. Okay, so we might, let me just minimize my screen. Right, okay, so I'll just touch on a bit of background. So I'm going to talk a little bit about myself and my health inequalities journey. And I'm going to look at the past into the present, because very, very much is my work around the kind of colonial history and where we are in the present and how that actually impacts upon health inequalities. Then we'll look at the Caribbean and African health inequalities, so specifically looking at getting that magnifying glass out and looking at what are those disparities within the Black community, and also what are the kind of barriers to addressing some of these. I want to talk a little bit about CARN because it's really important, and it's an outcome from some of the work that we've been doing, which just really talks and emphasises how much CARN is rooted in community, rooted in grassroots communities, So I'll talk a little bit about that, and a survey that we did in April and some of the findings and how that really confirms where we are as a community in terms of health. And then I'll just tell you, and I'll just end the presentation by looking at the PhD findings, which is due to be submitted in October. So I just want to share with you where we actually are going with that once that's been submitted. Thank you. Right, so I just want to talk a little bit about myself. So I was born in Manchester, just down the road from where I'm in Ernton at the moment. So I was born in Manchester many moons ago now, and I was raised by my parents, and I don't know if they're on the call, but I was raised by my parents, Gloria and Ivan Ruddock, who came here in the 1960s, and they brought me up in the church. So they came in the 60s, and like many other people from Jamaica, they came with, you know, many religious values and, you know, set up. And my dad was one of the originators of the New Testament Church of God in Manchester. So that church that you may see if you're from Manchester without the steeple. So he's been there all of his life here as he's lived in Manchester. And he was a deacon in the church there as well. So it was very strict upbringing in the church. We used to do all the prayer meetings at home. I remember on a Saturday night, we'd do all of that before going to church in the morning. And I just remember my dad just religiously committed to his role as a deacon there, you know, opening church and, you know, just doing all the officer, you know, duties, real commitment, and mum stuck by him all the way. So really solid upbringing that I had around the church. So I'm one of 7 children. I'm the second oldest, and as I said, I was brought up in the church, but just even though I was brought up in the church and I thought I was really quite good, but actually in school I was not very good. I was really quite a naughty little girl in school. I gave my mum and dad such heartache. You know, I can see how it happened now as I've got older. But I actually left school with no qualifications whatsoever. I was one of those, you know, that were told you'd never amount to anything. You know, you'd never, you know, get any qualifications. You'll never have a decent job. You know, if you wanted to do running, you know, then maybe you'll be okay with that, but not really much else. So, you know, I was one of those girls that were told that. I left school with no qualifications, but there was hardly no investment in me to actually achieve anything. And I went to catering college, and I didn't do very well with that either. I wasn't a cook. I wasn't really going to make it in catering. But what did happen was I went on a placement to a place called Corner House. I don't know if anybody knows it. We used to be on the corner by the Palace Theatre. And I went on a placement there, and I met some incredible people. It was a very kind of trendy place to be, and it was very much about, you know, university students and university life and all of that. And I had my eyes open thinking, actually, you know, I'd like a little bit of this. You know, I want to go to university. So I dropped my catering college course after the first year. It was a 2-year programme. And I decided I just thought, it doesn't matter that I've got no GCSEs or O levels as they were. I'm going to try and get my 3 A levels. And I worked really hard. In 1 year, I managed to get my 3 A levels to go to be one of the first students of nursing to do the nursing degree. So it was a fairly new thing then. It was the Project 2000 just before that. And so I was one of the first, and certainly one of the first Black students to do nursing and doing a nursing degree. And I had it was a nightmare in terms of the kind of, you know, critics and people still not thinking, you know, why, you know, a Black woman, you know, there's hardly any, it's a very new programme. It's a degree at that. And we have a Black woman doing a nursing degree. This isn't what we're used to, because it was very much about, you know, people doing enrolled nursing, you know, which is the second level of nursing, but certainly not doing degrees, because degree nurses were all going to be lecturers, and they're all going to be researchers, they're all going to be managers, and you didn't get Black people doing those kind of things. So, but I persevered. I really wanted to make a difference. my upbringing and what I saw within the church community in terms of the numbers of people, like my mum and dad's age, when I was going through church, you know, they were like in their 40s and 50s. And I used to see lots of people getting really ill, you know, and dying early. You know, some of my friends' parents and mothers in particular dying from strokes and things. And I wanted to do something about that. I wanted to find out why that was going on. And I wanted to see how I could help. So that's why I chose nursing as a career. I've since had 3 children of my own, and I'm particularly proud of my 3 children. They have done through thick and thin. They've worked incredibly hard, but I won't talk to you too much about that because, you know, I could go on forever. I'm sure many of us could go on about our own children, but they've worked incredibly hard to be where they are today. So once I'd been, you know, I qualified, got my degree, I did my nursing in the hospitals, I did it in Sheffield. I again was met with barriers in terms of getting my nursing career, getting a nursing job. But, you know, eventually, yes, I did get them at my nursing job and worked my way up to team leader, just because I was quite pushy and quite determined to actually make a difference. But I wanted to go into teaching quite quickly, because I could see how the way that nurses were being trained or taught didn't actually address some of the issues that we were seeing, you know, in terms of people's health. So, you know, whether, you know, our patients weren't being treated with kindness, with compassion, you know, and I wanted to get into the classroom to actually do something about that and to change the way that people saw people that were largely different to them. Once I'd got all of that, you know, and I was into the university I'm teaching now, I decided to do my master's, which was a master's which wanted to look at why or whether the then primary care trust, how did they engage with communities? So we could see what was happening in the hospitals, but actually what was going on in the community around health prevention. You know, what was actually stopping, you know, Black people actually, you know, getting ill in the first place. And so I wanted to see the level of communication. You know, did, you know, primary care engage with people within the churches? We know in the Black community, over 84% of people go to a church or have some affiliation to a church. So really, you know, what was the level of engagement? And obviously in that master's, I found out there was virtually no engagement with any of our communities. Sometimes they would contact them to come out and do a session. Many times people would, you know, would commit to doing that, but then not turn up. So it was certainly not something that they were used to, getting health prevention information. So did my master's, wasn't really quite happy with that. In fact, before I did my RCCOL, I started my doctorate a good few years ago now, because I wanted to continue that and to find out more about some of those communications and that health prevention information and how it was actually filtering to our community to actually change, whether it's the behaviours or, you know, what were the hidden factors that were actually sustaining the poor health outcomes that we see in the Black community. But in between all of that, I've done a Mary C. Cole Scholar Award, which was basically looking at a community leadership programme for faith leaders, Black faith leaders, because, you know, as we know, many Black people go to church, and it's almost like a most suitable or appropriate environment to actually get health information out. But what were the actual the faith leaders, what did they know and understand about the healthcare landscape, and how did they navigate and provide support for their congregants who often would go to them with that kind of health issues? You know, did they know about signposting and all of that kind of thing? So we wanted to have a look at that and really explore that, and that produced some really interesting findings. So I'm now still on my doctorate, and you know, I'll tell you about the findings at the very end. Okay, thank you. So one of my most favourite kind of scholars, you may have heard of Frantz Fanon, and he provides a really powerful account of some of these personal and collective experiences of Black people. And he was a psychiatrist, and what he was saying way back then was about how colonialism and racism and social injustice really causes some of the physical and the mental ill health that we actually see, and we can actually see that today. Thank you. So if we look at the past and to the present, we see that there is a kind of theme that runs through. And one of the real kind of revelations is because what we've tended to do, so when I was doing all my literature searching around health inequalities, and what I was finding a lot of was that there were lots of biological explanations for health inequalities, and therefore you'd get some of these health prevention kind of interventions to try and address some of them. But actually, over the decades, and despite all the health legislation, the health strategies, the actions, plans, and you name it, regardless of all of that, we still see some huge and varying health disparities in the Black community. So this is all about unpacking why that still remains, what are the hidden factors. And one of the things that's recurring, that's coming through, is that when we look at the legacy of colonialism, we see that kind of intergenerational trauma that just goes through the generations, and we see some of these genetic kind of changes in terms of, you know, why we're more likely to have a stroke, why we're more likely to have diabetes. So we can put that down to some of that legacy of colonial history. Okay, so what we know is that there are the effects of interpersonal racism, and we know that some of that racism can be overt, and it can result in physical violence or verbal harassment. And we're just thinking about all the impacts that that actually has on your physiological responses to some of that racism. We have the racial microaggressions, very, you know, what we see today, and what people used to say when they came to this country, like my mum, and, you know, people used to say is, you know, it used to be very, very overt. People would just say things to you, but now we know that it's very, very undercover, and it's really hard to kind of catch people out and to actually, you know, to say that they're, you know, they're being racist. But these are all these microaggressions, and also that thing about undermining people, you know, and I shared with you just a little bit ago about some of that when I was going through school, you know, and how that makes people feel and how that can impact on people's mental well-being. So these things have a real significant impact upon people's mental and physical well-being, that it actually results in what we call weathering. And so it's even like when you think about the perceived level of, you know, perceived racism. So often, you know, you hear people that talk about, you know, even getting ready in the morning to go out of the door, you know, and how you've got to think about how you're going to present yourself. And, you know, even that creates this level of stress. And all the time, this is causing these biological changes that increase people's blood pressure because of the anxiety that it causes. And one of the things that we do know is that with Black people and health, if you look across nearly every health indicator, whether it is, you know, about stroke or prostate cancer or any of those things, you'll find that within the Black community, we are more likely to get it at a much younger age. So that thing about weathering, it actually takes its toll on Black people and produces some of these, you know, earlier, you know, mortality and morbidity that we see. And I'll talk about benchmarking in just a second. But yes, depression, anxiety and stress and all of that can cause those physical outcomes that we see. So some of those underlying health conditions, and many people will have been hearing about it through COVID, you know, what do we mean by underlying health conditions, pre-existing conditions? And when we think about the, again, the Black community, we are more likely to have those underlying health conditions. And just to say that the root causes of the racial disparities is just really looking at institutional structural racism. So we can see the income inequality, you know, we can see how many of us are not in high paid, well paid jobs, you know, tend to be in precarious roles. So there's huge disparity there. The health conditions I've just mentioned, the environmental injustice, while many people tend to live in areas that are not particularly, you know, free of pollution, housing inequalities, less access to those nice spaces and places where people feel confident just going out and just walking. The disproportionate representation in close contact. So we're really kind of focusing on COVID here and some of the reasons that you've seen for the high prevalence of COVID and disproportionate mortality rates is because of a lot of the occupations that we tend to undertake, you know, whether it's in the transport industry or in health. You know, many people have said to me, they've lost their jobs. Some of them have, had about 4 or 5 cleaning jobs, for example, trying to make ends meet, and all of that, close contact with people all the way through COVID. And also the rates of unemployment. We have such, and you might have a session already on this, but the high rates of unemployment that we see within the Black community. And even though many of us will come out with the same qualifications from university, for example, we often do not get the same access to those jobs and also those salaries that somebody of the same qualification would also have. So in terms of what we already know about the Caribbean and African community is, and this is something that I've taken from the Caribbean and African Health Network, which I chair currently, because what we've focused on are the most prevalent health conditions within our own community and where we see such huge health disparities. And my PhD really started off with cardiovascular disease because I wanted something to hang my PhD onto. So basically, if you look at cardiovascular disease, much of that can be prevented. So you can see how, if you've got a good diet, if you do physical activity, if you're less stressed, if you get more sleep, all these kind of things around cardiovascular disease, to reduce cardiovascular disease, it is preventable in most cases. Some of it can be passed on, but generally, we can see how that could be a preventable disease, but yet we are 3 times more likely to have cardiovascular related diseases such as strokes and diabetes, etc., etc. Again, with cancers, again, you may know that we're more likely, our men are more likely to have prostate cancer at such high rates, but yet we have no targeted screening program for people at risk of prostate cancer. Other things like liver cancers, bowel cancers, and a lot of these things, you can see how they come from that colonial past that actually causes some of these disparities that we see today. Can I say anything about mental and emotional health? I mean, if you just go back, mental and emotional health is such a big issue in our community. Again, we can see some of the impact of racism and discrimination, which is reaping some of these mental and emotional and poor health outcomes in our community. Blood and bloodborne and immunological conditions as well. Again, some of those stresses on the immune system that causes some of the, stresses and flare-ups that we see, the sickle cell, and some of the other blood disorders, HIV, etc. So we kind of focus on the things that are particularly more prevalent, but also the things that we know that structurally they're not actually being addressed. So if we just go back to cardiovascular disease, that I say this all the time. If we know from the evidence base that the Black community are more likely to have, high blood pressure, high cholesterol, strokes, and all those kind of things earlier, then why do we have a national screening program that just targets people at 40? Because a lot of it is benchmarked to white majority populations, and we don't really take into account differences in some of these programs that we actually have. And then finally, just the reproductive and sexual health. So we focus on maternal issues, sexual health issues, some of the high rates that we see in there, and HIV would come under that as well. And again, I'm sure you've heard me talk and Charles talk about, the maternal mortality issues that we see, where we know that, Black women are 5 times more likely to die in pregnancy in 2019 from the Embrace report that came out. And I was talking to somebody about 3 weeks ago that's really quite senior in maternity, because I've got another role there as well, and said these reports have been coming out since the 80s, but yet they said every time they came out, every few years they came out, they sat around the table and they looked at it and thought, you know, we need to do something about this. But year on year and year, they did nothing about the maternal mortality rates in Greater Manchester, where people were dying at that rate. I mean, it's progressively got worse. It used to be 3 times more likely. Now it's 5 times more likely. And we also have our babies that are 122% more likely to die from infant, you know, to die in the first month of being born. So we've got some real issues there that we're looking to address. So just really quickly, I'm not going to go through all of these, but really we have a problem. We have issues around poor access. There are real and, you know, serious issues around lack of trust in healthcare from our community. And that lack of trust will lead to delayed presentation. So we tend to get the worst outcomes because we get to our, you know, to our healthcare providers late. There's a lack of knowledge as well. So if there are people not like me, you know, it's very unlikely that a lot of the research will be done around some of these health disparities and trying to look at how we address them. And then, of course, we have the structural systems and the lack of investment in Black health, which I've given you just a little example of that one. And again, I'm sure through across a lot of your presentations that you've had over the past few weeks, we've talked about, you may have heard about the lack of senior representation from people in the Black community. And again, when I talk about Black community, I'm talking about Black, Caribbean and African people. So we can't be, you know, homogenized in a way where we're all lumped together and we say, yes, we tick all the boxes, because if you actually look at Black people in decision making senior roles, they're not there, and certainly across Greater Manchester we don't see that. Benchmarking against majority populations is a huge problem in terms of health inequalities. If we just take the one thing, you know, that came out so strongly in my PhD about something like the Eat Well Guide, which was a £3 million project from Public Health England that looked at, you know, how do we reduce, you know, cardiovascular disease and all these other things. And we have an Eat Well Guide that's just predominantly of English foods. It has no, you know, people didn't connect with it, people didn't use it from our communities, and therefore it's not going to actually help in that health prevention. Racial discrimination and conscious bias, we know that exists, and there have been lots of different programs and workshops and things to look at how we can actually, you know, get rid of that or get people to become more aware of their unconscious and conscious biases. And then we have the poor community engagement and investment. And, you know, as I said before, we tend to have a lot of Black people that do affiliate to church or go to the church, but yet, you know, the place where you can actually reach thousands of people every single week when the churches are open, even when the churches aren't open, you know, you get a lot of engagement online, and yet there is very little engagement from, you know, the decision makers or health system in that regard. So I'm just kind of like starting to wrap up on this part of it. So we have, you know, despite what people think, there is more difference within the races than there is outside of the races. And one of the things that I have always said in all of my interviews and conversations with people is that what I didn't want to see happening, especially through COVID, was that there was going to be a conversation about the genetic disposition to become more likely to die from COVID-19, as though there is something that is inherently different about Black people that predisposes them more to more severe COVID-19 outcomes. And what we do know is that it's about a social predisposition to COVID-19. So as we were talking about the income inequalities, and although we know that we've had many people from senior positions, so consultants, you know, etc., that have died from COVID, we know that there is a common denominator in a lot of what we've actually seen, and that is about people that are of colour, that tend to be the people that are victims of COVID-19 in terms of mortality. So there is nothing genetically different about us that predisposes us to COVID-19 or any of the other health conditions. It's more about an intergenerational pattern of disease that we have, and that goes way back to colonialism. I've mentioned we have a high burden of chronic disease, and also about those everyday stresses that take its toll upon Black people, that actually changes that genetic expression. So when you see that my mum's had high blood pressure and then your mum's had it, and then it just kind of goes through the generations in that way, but it started somewhere. And that this is the toxic combination that puts us more at risk of complications, for example, from coronavirus. We've all may have seen the statistics on the disproportionate impact from COVID, and we say, well, crikey, you know, it's 4.9%. And 4.8% more likely. That's when you take into account all the socioeconomic and underlying conditions. And if you don't take into account, we're still almost twice as likely to die from COVID-19. You know, but then again, we say, you know, we're 5 times more likely to die from maternal mortality. You know, so it's all the same, coming down to the same reasons. Okay. So CARN, the Caribbean and African Health Network, is all about, you know, taking all of that on board, looking at all the kind of research and just what we know about our community. We set out in 2017 to look at how we reduce health inequalities, influence the policy and practice. So we have almost like a social movement, really, which is about how we get collective action to challenge some of these inequities that we see and unfair systems. So interestingly, when I was doing my research and I was saying, you know, not that I was preempting what the findings were going to be, but an 85-year-old lady came to me as she was part of the consultations that I did. I had way over 100 people in my consultations, which was fantastic. But an 85-year-old came to me at the end and she said, you know, I never thought in my lifetime that I would see something like this. I've seen her since and seen her at some of our events. And absolutely what people have been saying is that we've been crying out for something like this for so long, because we talk amongst ourselves, we experience such poor outcomes, we don't know how to challenge and hold the system to account, and we need a kind of a body to be able to do that on our behalf. So we as CARN came together to actually, you know, look at how we address that. And so we work with decision makers to address the causes of health disparities. And this is about that collective voice where we all come together, so we're more likely to be heard about what the issues are. And a lot of my work is very, very much focused on the voice of the Black community. I don't want it to be my voice, I want to hear them, and hence my PhD is also focused on centralising the voices of Black people. And we look at how we co-design some of those services together in a culturally and religiously appropriate way. So finally, just talking a little bit about the survey that we did. So we, as an infrastructure organisation, we came together in sort of set up a collective community forum so we could show leadership about how we were going to be addressing COVID, because even before the government was announcing about all those with underlying health conditions being, you know, being shielded, etc., we already started to do that. We put out our newsletter, we knew about the risk, we said, well, actually, we always know if there's something bad, Black people are always going to get it worse. So we knew we had to do something to actually address that. So we brought together this collective community forum, and we've been bringing decision makers to the community to actually look at how they, you know, they can ask them questions and how they can, you know, what kind of responses we get to actually get some action on some of these issues. So we started the survey. We've had lots of findings that's come out, things around mental health, concerns around the educational needs. Again, you probably know about the predicted grades and how unfair they are more likely to be. The treatment of frontline workers, high rates of people down in the community, the resources that Black communities get. I mean, you name it, I could go on. There's a long list of things that were actually people were concerned about. And we had a number of recommendations, but really it's about investing in the Black community. We've not seen, devolution is here, but in terms of the Black, African and Caribbean community, there has been very, very little investment, given the fact that we have the poorest outcomes across many of the health indicators. What Black people were saying, we had way over 300 people complete the survey. And one of the most stark statistics was around how Black people wanted to have Black-led services, because I've mentioned before about the lack of trust. You know, people were kind of fed up with all that was going on and just wanted to be, you know, to be able to have, you know, those services met by people that looked like them. And it wasn't about segregation or anything like that. It was about, you know, they needed to get the health, education, that, you know, that level of investment, and, you know, the Black-led services were offering that. So in terms of findings from my PhD, the participants, you know, across all of my studies didn't say that we wanted to decoloniate the health system or healthcare, but everything that they said pointed towards that. So I'm listening to their voices, and basically what they were saying is the system is very, very much built on the colonial past, and we need to be able to look at how do we break down some of those power structures. And, you know, that's where the kind of the PhD moved to over the last, you know, 5-6 years. It's moved towards how we're pulling that down. And we've already started to do some of that work through CARN, but, you know, we're really looking at how do we look at some of these, you know, some of these policies and practices and change them to get some equity in the Black community. If you just go back, please, Charles. So as I said, my PhD is to be submitted, and then, you know, that's going to be the theme of what I am going to be submitting. So in terms of conclusion, what I would be wanting to leave you with really is, you know, the real need for us to engage in conversations and to take action to address health inequalities. And I think it's really all of our duty to look at how we can do that. The Black community can't do it on its own, but we need to continue having the conversations. And some of the conversations are really, really quite uncomfortable for some, but we need to have those honest conversations about how we address health inequalities. Lots of lobbying and campaigning, we know, through Black Lives Matter. You know, there's a real movement, and I remember starting all of my work. The Black Lives Movement campaign was starting then. You know, it's almost seems to have died a death, but it seems to have revived now because of the tragedy that had happened that we've all seen. But the Black Lives Matter is a movement that we've been talking about for a long time. I mean, my PhD posters were all about Black health matters. That's what I was doing in 2013. And just to say that it's not enough to say I'm not a racist. It's about what we actually do. We actively need to challenge racism and discrimination, just like we saw in the Malacca, doing all that work around the van that was vandalised on Sunday, back end of last week. So happens to be my cousin's church. But yeah, all lives matter. You know, we're not, like Malacca was saying earlier, it's not about any life not mattering, but it's about where we are in terms of that. You know, our lives have never really mattered, and we need to see change, and we need to be able to work together to stamp out that inequity across all of our institutions. Because if you look at the social determinants of health, we know that it's not just about one area, one institution, one agency. It's about all of them working together to stamp out that inequity and that unfairness. Okay, thank you.
Thank you, Faye. That was forthright, enlightening. I'm not quite sure all-encompassing, because I'm sure there's probably still more that we could sort of uncover and realize. But I think you've certainly helped us explore massive amounts within there. So one question that's already come across was, is there any chance of us having a copy of the slides at some point?
Yes.
So,
Yeah.
that'd be good. Thank you. So, but yes, would anyone like to ask a question? We've got about 10, maybe a tiny bit more minutes left. Would anyone, if you want to indicate with a hand? I see that Fayette's put something in the chat. Yes, Lauren, please.
Hi, yes. I know that Faye, towards the end of what you were discussing there, you talked about that the systems based on the colonial past, and you talked about how you're starting to break down some of those power structures. Can you give any examples of some of the work that you're doing now to start to break down those institutional power structures in particular that you were mentioning?
Yeah, so I'll take one example. So when we talk about maternal mortality, and I mean, I'll talk about maternal mortality, but I've often actually referred to the near misses, because that's the thing that we tend not to talk about much. One of the things, as I was saying before, it's about how nothing was done. You know, nothing has been done about the high rates of maternal mortality and infant mortality of Black children in GM. And what we do is we challenge them. So basically, as a result of, we went to the Greater Manchester Partnership, and we said, you know, we have the national data, where's the local data? Can you provide that to us? Our community was saying, what is Cairn going to do about this? We wanted to be that leader that was going to do something to actually hold the system to account for the fact that they hadn't done anything. So we finally got the data which reflected the national picture. And what we've done is we've managed to bring an advisory group together at the partnership that's got, you know, people from right across the sector to actually look at some of those policies and some of those practices, to look at how we change those. You know, why is it that, you know, just take, for example, the recruitment of student midwives. So student midwives at the University of Manchester, we have in one cohort a couple of years ago, 100% white. Why is that? So we want to challenge everything, so that it's not just about one part of the system. So we've brought together, you know, a range of people from across universities, across the health, you know, the trust, to actually look at how do we almost dismantle, unpack some of those, what we know is causing a lot of these disparities in maternity. So that is just one example of what we're doing in terms of, you know, the power structures, you know, to break some of those down.
Thank you, that was really interesting.
I'll unmute myself when I was talking then. Thank you, Lauren, for that question, and Faye for the answer. Fayette's mentioned about in the chat about a book by a British Black doctor who's written about differences in diagnosing Black people, and how medical books teach sort of mainly for about white perspectives and white patients and things. And in your experience, Faye, is there, as Faye, do you want to ask it, but is there a perspective on how the average doctor is educated on diagnosis of Black people, and should there be any differences?
Absolutely, absolutely. I mean, gosh, I could go on forever on this one, but interestingly, and I'm sure Charles won't mind me kind of saying, because we know there's a problem. And we know that, I mean, all of us, we could probably get 5 or 10 minutes with a doctor, but in terms of how we articulate ourselves in the doctor's surgery, and how doctors tend to kind of like use a kind of stereotypical diagnosis to give to a Black person, just because that's what they think they may have. And so what we're actually looking to do, and again, this is how we are looking at changing the system, is to look at a programme which educates primary care about Black people. You know, we haven't all got mental health problems, you know, we haven't all got schizophrenia. You know, there is almost like a kind of quick judgment that is, you know, a diagnosis that we're going to get. So we are looking to educate primary care about how, you know, about some of our religious behaviours, some of our cultural issues, and just to get some kind of understanding, or get them to have some understanding of who we are. You know, it's sad to say that in 2020, you know, there is still a lot of stereotypes from doctors about Black people. So that is part of what we're actually looking to do, roll out a programme that does education for primary care and taking some of those kind of prevalent health conditions and why some of those things may actually be happening. So not from a medical perspective, but more from a religious and a cultural perspective, we'll be looking at that.
Thank you. There are two more comments in the chat, which I'll sort of ask you to comment on. One is from Tom, who points out that there are high disparities in mental health outcomes, and yet obviously we're dealing with a badly flawed mental health system, but there's a need to strive for greater equality within it. And then Jane's mentioned about the NRPF issue for Black migrant women. The effect is proving fatal. Can you comment on both of those, maybe?
So what does the abbreviation stand for, the last one?
No recourse to public funds.
Oh, no recourse to public funds. Yeah, huge issues around mental health and outcomes for Black people. As you know, many of us know that Black people are more likely to end up, you know, in mental health care through the criminal justice system. And you know, it's just interesting how people end up there and then the treatment that they get. I mean, I'll just give you just one example of you know, a patient that ended up, you know, has got sickle cell anemia. You know, it's a condition that particularly affects Black people, and going into A&E. So first of all, we have issues around people, if you're of a particular kind. So maybe if you're a big Black man who needs some, you know, who needs an ambulance. So he's actually in excruciating pain, you know, with a sickle cell in a crisis, and, you know, rings for an ambulance. Ambulance turns up, refuses to take him because he actually thinks he's going to be a risk to the ambulance crew. We actually get people like that ending up in A&E in excruciating pain with sickle cell. And basically, because they may be rolling across the floor, people think that they you know, they've got a mental health condition, and then they end up giving them an injection you know, to try and calm them down, but not pain relief, but thinking that they've got some kind of mental health condition. And there's a real misunderstanding about, you know, a lot of, just because of some of the behaviours and some of our cultural behaviours as well, you know, actually putting that down to kind of like mental health illness. I think there's a real lack of understanding of Black people and mental health in this country, and you know, and a lot of that is, again, you know, colonial, you know, and you know, we just need to get in there and change the system. We just need to change some of those stereotypes that exist, because, you know, Black people are becoming iller and iller, you know, with all kinds of issues, whether they end up because they may have started with anxiety and depression or something, you know, like kind of low level mental illness, ending up with lots of physical conditions, and it's kind of so unfair, the system, in terms of how it actually treats people. So mental health, they always say, you know, and we know that Black people are more likely to have mental health illness than any other group. But then if you think about it, why that actually happens, but still, even when we do get mental ill health, we're more likely to end up in the hospital through the courts and then not get treated properly, get more harsher treatment as a result of that. You know, whether it's, you know, injections or, you know, restraints and things like that. So it's, you know, we've got a long way to go, because that's what we're still seeing in 2020. and women and people with no recourse to public funds. You know, again, you know, people are, you know, what can you do if you don't have any access to, you know, to funds? You know, people will suffer, or people will use their voluntary services to get those kind of support. And, you know, what we know that there is a huge risk of, especially through COVID, is that a lot of voluntary organisations are going under because they don't have the investment there either. So, you know, we have a huge issue all round.
Thanks. And Fayette, I can see your hand raised. So if you'd like maybe to ask the last question, please.
Hi, yeah, I just wanted to go back to the diagnosis point that I was making. Once you get beyond even, I mean, it's difficult to even, as you said, get the trust, then get the doctor to take you seriously. But my point about the diagnosis is that even something as simple as measles, for example, presents differently on black skin than it does on white skin. And I think that most doctors are not trained to notice the difference. So even once you get past the trust issues, even once you get past the conscious and unconscious bias of the doctor, when things are presented, they're not even aware that these are actual, yes, they have the illness, and get sent away. What investment is being made and what efforts are being made to actually educate the doctors medically, just on a medical basis, not, you know, without all the extra things that we're talking about. They have to be able to recognize for the people to even begin to get the treatment.
Yeah.
So thank you.
Yeah, no, absolutely. It's always been a big issue, and it's been a big issue in nursing as well, because of course, you know, we talk about something like, even like pressure area sores. You know, if you talk about, you know, if anybody's, you know, nursing or medical, you know, when we talk about how, you know, people's skin breaks down, you know, how do you see people's skin breaking down on a black person? Nobody ever teaches you about anything like that. You know, we were talking about that in maternity at the moment. We were talking about jaundice on black people, you know, and on black children. You know, how do you actually assess that? People do not get taught that in hospital, in their medical and nursing training. And it's only if you've got a passion for it and you're interested. So, for example, I will talk about that in my when I'm educating, you know, my nursing students. You know, we just know that it's not part of the curriculum. So there is a lot that we need to do around that. But that is all, as I say, you know, we are all about how do we educate the system to be able to recognise and treat people, you know, fairly and accordingly, and to get the right treatment. You know, it's really, really important that we, you know, we unpack all of these things, you know, so we actually get the better outcomes than what we're seeing at the moment.
Thank you. Thanks, Faye, so much for leading us through this evening. It feels that there's a lot more that we could and should be looking at in this area. So I sincerely hope we do get the chance, make the chance to come back to this together at some point. It might not be in the next 2 seminars before the end of this series, but I think there's a lot of scope to come back to this. So Faye, thank you so much. Thank you, Charles, also for sort of clicking with the PowerPoint. We look forward to being able to circulate that to people so that we have that. So thank you all. And Jane, do you want to say a few words about what's happening next week for us?
Yeah, I'll do that. Can you just switch to speaker view?
I think we all have to click our own to get to swap that.
Do we? Okay.
I can't sort of control everyone else's screens. If you want to speak view, so you can see Jane on the Andrew and Jane fine. So
thank you very much for joining us this evening and being open to new evidence, new knowledge, new things to think about and to share in your family and your friends. We have to join in this conversation. Next week, we're going to have somebody who's going to help us look at experiences of parenting and education for Black people. Yeah, so if you've got questions around parenting and education, then please bring them with you next week, and please share our details if you know others who might want to join in this snowball of conversation. Thanks, Warren.
Thank you all. So again, thank you all for continuing with us, for being part of this process and journey. Thanks to Malika and Jane for helping to push this along as positively it has been. We did miss out last week on our guest speaker, but in 2 weeks' time, we'll have the opportunity to explore with faith communities again, Black experience within that. Although any of us who were at the church in Longside yesterday have an idea of some of the experience that is still being felt. But this feels to be a good process. This feels as though there was a stage where, Faye, you said something about we just have to change. It's amazing that tiny little word just is such a massive hurdle to overcome. And yet I'm quite confident that if we are in this together, we can make it much more little word again. So let's continue together. Thank you all, and have a good week. And we look forward to seeing you and sort of many more of our colleagues as well. We have over 80 signed up to this this seminar series. So let's hope we all see more of us and continue this journey together. It's not just going to be 7 seminars, as we said last week. We will find a way of continuing with this with a short break, maybe some action in between, and we're hoping for a conference possibly around Interfaith Week as well later in the year on this theme. So let's keep up the good fight and work for more equality and justice for all of us, especially our Black brothers and sisters. Thank you all.
Thank you.
Thank you, Warren. Keep safe, everyone.
Thank you.
Peace be with everyone.
Thank you.
You're welcome.
Thank you, Faye. Thanks very much.
You were amazing, Faye.
Amazing.
Thank you. Bye, everybody. Take care. Bye.
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 And then there were very few. I just saw someone there I hadn't actually noted down that he was on there.
The people couldn't get in because they needed the password or something.
If they click on the link, then they can get in. If they enter the meeting ID, they'll need the password.
Ah, right.
But that was circulated with the information. So
I told them not to worry and to email you, and you'll send them the recording.
yeah.
That's what I said to them.
On the email that Warren sent out, it had the Zoom link, the meeting number, and the password.
Right. Okay.
So I'm guessing that some people have. I don't know. It was underneath. If they've cut and pasted the meeting ID just underneath.
Right. Okay.
Password.
I get you.
Yeah.
Yeah. I mean, everyone who emailed, even those that had contacted you and then emailed me, I make sure I sort of send them the full link. So both the link and the password. So, but yeah, if it's just a password, I'm sorry, if it's just the meeting link you send, they'll need the password.
Okay.
So they need to note down both bits of information. So, but no.
So two numbers. They need both.
Yeah.
I get you now.
Okay. But,
okay.
Hey, that woman was awesome. Faye Bruce.
She was the best one we've had. Absolutely. She was the best one we've had.
I liked Akeem. Sorry, Akeem was good.
Yeah, Akeem was good, but Faye did it for me. What I liked about it was I like the slides and the statistics, and it just wasn't all her experience. That's what I liked about it.
But
Yeah.
I think we're building. I think it was
Yeah.
really important to start with personal experience. If we just come in as a just sharing facts, we would not be so winsome as we have become. You know, really, to really meet. So I'm glad of the order that we've gone through. I think Beatrice will do a presentation if when she sees that this alternative, you know, she'll know that she has permission to be a bit more formal, because so far we've, you know, when I've said, oh, look at what we've done so far, we've been a bit more chatty, and that might affect. I'm sorry, I just went blank over the woman's name for next week. That's why I didn't say her name, because I just went blank.
Right, yes.
What is it?
I hadn't actually spotted I hadn't spotted you hadn't mentioned her name, actually.
Oh.
You would, so fine.
What's her name?
Her name is Annalika Zoe, is it?
Annalika, yes. So Annalika, I will also tell her to have a look at tonight and feel free to do a presentation, because I think the ground has slightly shifted. We're if people really want to know some facts now, and this recurring message that things need to change. And I wonder if we might come up with a kind of a little charter for change at the end.
Yeah, we could do 10. That might be a good idea.
10 things that we want to see change.
Yeah. There's something else that's come to me as well, is that, and I'm mindful that we all need to go, but there is so many other areas like sport and faith, and I mean from a leader's point of view, criminal justice, but I'm thinking of, like, there's a black police officer that's just retired in Manchester, and I'm doing some other good Black Lives Matter work with him. He was with me last year. He was stood with me yesterday, actually. And what about business, media? We've got Mike Shaft in radio. He's been in radio for like 30-40 years.
Absolutely.
And
so you've mentioned 4. You know, if we wanted to pick up,
and I know
again in September,
I know a woman with, I know a woman in science, a black woman she's doing a lot in science for the black community. So that could be another. I
think we can clearly look at the topics, the issues, the areas that we can find people on, but also invite some of our participants to make suggestions of other areas and who maybe aim to do another 4 or 6 week session in the autumn. Leading up to a short gap, give us 2, 3, whatever. Leading up to a conference, and try and sort of engage things, and also see if we can get some action going in between as well, whether it's a charter, campaigning. So,
And meanwhile, our co-host is going to go stratospheric.
I think she's been in the wilderness for years. She's only going to realise it in a week or so. But yeah, Malika, let us know if you will be able to be online on Monday.
I'll keep in touch with you.
Otherwise, we might need a meeting maybe Friday before you.
Something like that. That's fine. I'll definitely keep in touch with you.
Right. Yeah. I was hoping to escape her. So.
Okay. Just tell us you will be quite busy, won't you, in these next 10 days? Is that right?
I leave on Sunday.
No, I meant Warren is.
Oh right.
You you said something.
It's the fast but I'm actually going to be there is a service on Wednesday evening. I'm doing a class beforehand. I've told them I might not even be around, but no, for the next period, it's the middle end of September when I'm actually going to be really busy.
Okay.
And possibly it could actually be just over 3 weeks. It's fairly manic, but we'll see how it goes. That's more of it's actually the weekend this year. There's a Day of Atonement Sunday night, Monday, so that'll be I'm out of action completely that time. So I won't want to be involved in something on the 28th of September, I think it is. But we can look at what we're doing, and
yeah.
we'll only have just had our sister back by then, possibly. So we'll have to see. So.
And just on a personal note, so I start this job next Monday with Manchester Young Lives. In one sense, I have no idea why a white woman is in this role.
Is it Angela Lawrence that runs it?
I don't know that name, and my boss is going to be Elaine Young, and somebody said, so I went to Withenshaw and said what I was doing, and the response from one of the play workers was, oh, we're 96, 98% white round here, so kind of we won't need it, what you're doing round here. And I thought, what's your job going to be round here? And I'm like, whoa, okay, there's a start line. I've actually
wow.
with the staff themselves, so they've got the money for this BAME focused work, and I will have to start with
an education program
with the staff themselves about why this is necessary and what this so that there's not, oh, why are they getting something special, like, that kind of.
Is it a white group or a black group?
No, so I'm being employed to support to enable black young parents to access what their white peers are, to make sure that they know it, that they have. So it's an empowering role, but ultimately it's to set up it's the foundations for, in the future they would like to have 3 family workers, not 1. So it might be just that my role is to set something up, because this should be black-led in the future. Maybe I'm just like a link because of the experience that I've had, but I do feel slightly odd. Of whatever their point scheme, obviously I got the most points, so they offered me the job. But
yeah, you obviously know this. Hopefully, you know the systems, and I think that's an important thing. Yeah. If you know and are used to the system, can introduce people to the systems, then that might be the step up that they need, and then can hand over from there.
But you can imagine that on this learning journey, of not speaking for people who can speak for themselves, is what I'm meaning, to make sure that I amplify people's voices or enable them to speak their needs or whatever, but not to speak for people, because I think I've come from a place where I thought the great thing to do was to speak for people. I hold my, and I've learned not to, but I still need to teach other people how to do that.
Cool. So if you're starting on Monday, you don't really want a Monday daytime meeting, do you? It'd be better for you.
So you mentioned Friday.
Yeah. Is the Friday any good?
Yeah, well, I have Ray, but I can just, if I know when it is, I can just ask Andrew to look after her while I speak.
Okay.
Yeah. Is that all right with you, Malika?
Yeah, that's fine.
Do you want to provisionally arrange a time now on Friday?
I can do any time. I've got a meeting at 4.
What about you, Warren?
10:30, any good?
Yeah.
So either that or at lunchtime.
Well, let's do lunchtime then.
Is that better for you?
I think
Yeah, do lunch.
I can say, Andrew, here she is. You sort our food out.
Okay. So what's
That's
that? 12,
fine.
4:31? What's better?
12:30.
Done.
Yeah.
Okay.
Done.
Malika, are you Malika or Malika?
Malika.
Just because 2 of your black sisters have called you Malika, and so I thought,
It's that Manx thing, isn't it? Malika.
Okay.
Yeah. Okay. Be well.
Thanks for tonight.
Thank
And
you.
I'll speak to you Friday, if not before.
Take care.
All right, take care. Bye. Bye.
Thanks.